Hey everyone, my name is Kay Mayordomo. I am a physical therapist in Northern California. Currently, I am doing home health PT and also do older adult fitness classes. And I'm also a TA with the older adult division of ICE Physio. Today, we are talking about a home health patient that I have who is currently bedbound and how we can use a fitness forward approach to regain some independence and mobility. So, recently, I made the switch to outpatient from home health PT for more flexibility as I went to the beginning stages of building a business. What I didn't realize is that I would have a lot of patients who are bedbound. I thought I would just have really deconditioned patients who need to regain function to be able to get out of their home and into the community again. I thought I'd have more post-op, but I have quite a few patients who are bedbound. And I guess the first thing that popped into my head once I realized that this was a lot, like there are a lot of them, is I wish I had seen them sooner to intervene before they got to the point that they were bedbound. But sometimes that's not something we have control of. So I think the beauty of ICE Physio and the older adult division of ICE Physio is that we get so good at scaling for every single patient. So even though I haven't worked with that many patients who were bedbound before, we're using the same principles in terms of getting people more mobile, getting them more independent, but now we're just working with a population who is really susceptible to things like pressure sores, infections, getting rehospitalized. So today we're going to go over how I managed one of my patients who is bedbound. So first we're going to go over the patient information. So my patient is in her 70s and has a medical history of multiple sclerosis. So she has a lot of spasticity in her knees and just lower extremities in general. She has a lot of deconditioning. So her use of her lower body is pretty limited. Her upper body strength isn't too bad, but she still definitely has difficulty with certain tasks that we'll talk about later. She also had a pressure ulcer in her sacral region that had healed. She also has a history of hypertension and overall deconditioning from just being stuck in bed. So she also noted some right hip pain as she usually sits slightly to the left. She, like I said before, she has contracture. Well, she has spasticity, but also a little bit of contractures in both of her knees since she doesn't get moving that often. She lives in a care home. So if you don't know what that is, it's a house where there are multiple residents and patients residing there, and they have assistance with eating, dressing, toileting, and whatever other tasks they need help with. She has a hospital bed that moves up and down, but she has really lost a lot of mobility and needs mod to max assist for bed mobility. So for rolling, any kind of shifting in bed, like scooting up in the bed, she needs mod to max assist. Sometimes two people, depending on who's helping her. And for supine to sit transfers, she's unable to sit at the edge of bed without assistance. So we are at max assist for that right now for supine to sit transfers. And also she can't sit at the edge of bed without support. So I would say that's also max assist. So the patient and I discussed what to prioritize getting back to. She wanted to improve her ability to roll onto her side to prevent future pressure ulcers since she just had one that healed. She wanted to build more core strength to be able to sit at the edge of bed with less assistance and support. We're kind of aiming for min to mod assist, and then we can always talk about being more independent with that as the time comes. But I think we really needed to focus on realistic goals. Otherwise, if we focused on like the super end goal, might feel really hard for her to attain. So I was going to save that for when we reach these smaller goals first. And so the exercise program that we started to incorporate was, well, first, as fitness forward providers, we still want to make sure we are providing the patient with intensity to get better. Just because this patient is bedbound, this does not mean that we are just doing ankle pumps in bed. This does not mean we're just doing passive range of motion to prevent like more contractures. We are trying to do the best that we can to figure out, okay, what is the most challenging version of the exercises that we normally do with patients what is the most challenging version for this patient that we can do so that she can see improvement. So to start off, we did 3 to 4 rounds for time of 1 minute Pallof presses and supine. So I just had her bring her hands towards the ceiling, arms straight, and I pushed left and right to try to get her core working, especially obliques, because she's going to need to utilize that for rolling in bed. We did 5 reps each side, rolling left and right with mod to max assist, I would say. It really depended on the day, but I would just give her as much assist as she needed and had her do the rest. So we would do 5 to one side, then we would do 5 to the other, and then we would do 10 reps of single arm rows using a heavy resistance band to help build pulling strength for rolling. So we did 3 to 4 rounds of those 3 exercises, and as she's gotten better with things, I've taken things out, put stuff in. So we started to add crunches into that mix too, because although she can't do a full-on sit-up yet to be able to support sitting at the edge of bed, we started doing crunches to start building up to that sit-up. We tried to do it banded, but it was still just too much, even with a really, really thick pull-up band. But we will get there. I think we can get there. Patient education for the care home employees. So if you've ever walked into a care home, I feel like there's always a lot going on. Like they're either prepping meals for patients, they're helping a patient with toileting, they're just managing a lot of stuff. So sometimes having them work on exercises with the patient just seems kind of impossible. So I tried to take this, I tried to make it as simplified as possible. So their routine was to be adding in 5 reps of rolling each direction, left and right, after every time they change the patient. So after they change her adult briefs, I wanted them to do 5 reps of rolling in each direction, just giving the patient as much support as she needed. And I really feel that by adding it into their usual routine, it made the task less cumbersome for the staff who has to take care of multiple patients. And she's getting changed multiple times through the day, and I'm okay that it's not like 3 sets, 4 sets all at once. I just wanted it to get done. And if that's what it took for this exercise to get done while I wasn't there, that's totally fine with me. Also, I feel like since I didn't feel like the Pallof press would get consistently done due to the caregivers and like the care home staff's busy schedule, I gave the caregivers the rolling after changing, but I also gave the patient crunches to work on core strength. Sometimes I'd have her do more bicycle type crunches to get the obliques a little bit more, and a banded row where she could just hook a band to the side of her bed and start pulling from the opposite direction across her body to get some of that pulling strength she needed to pull onto the bed rail and get herself rolling. So the crunches and the rows I did with a lot of volume. So I had her do 12 to 15 reps and had her try to do it fast so she actually really felt it in those muscles, because I really just wanted her to get the intensity we needed. And it's hard, sometimes it can be really hard to add load to a patient who is bedbound, just because they might not have weights available to them, or the weights might be too heavy at first. So we were utilizing some tubing that she had and just added some volume. And I told her if 3 or 4 sets became too easy, she was going to add a 5th set for me, but we haven't gotten to that point yet. So the progress we noted so far is that the patient needs less assistance with rolling onto her side. So before she needed mod to max assist consistently, now I would say it's min to mod. So it really depends on the day still, but we can consistently get min to mod assist for rolling left and right. She definitely has an easier time rolling to the left because she likes to lean towards the left more, but the right side is going to the right definitely looks better for her rolling. There are no new signs of pressure ulcers, which is awesome. I think a lot of the times they just spend so much time on their back and there just isn't a lot of airflow getting to that area. The tissue starts to break down, but she hasn't had any new signs of pressure ulcers in the last couple of weeks since I've been working with her. And we discussed okay, things are improving, you're getting more independent, you're able to do some of these tasks more easily than before. where do you want to go next? So she definitely wants to still get that seated at the edge of bed goal. So that's why we have the power presses and the crunches in there to build up some core strength, because she just starts to fall backwards when she sits usually. And we still want to build upon the rolling so that the care staff so that they don't have to do as much. So today we went over a case study of a 70-something-year-old female with a history of multiple sclerosis who has spasticity in her knees. She also has a little bit of a contracture in her knees too. Just overall conditioning, a history of a pressure ulcer in the sacral region that has healed. And we discussed goals on how we can improve her function even though she is currently in bed. The key to note here is that we can still take a fitness forward approach to improving this patient's mobility and preventing pressure ulcers and improving more independence so she doesn't have to rely on the care home staff to roll to relieve pressure. We utilized rounds for time of pal-off presses, rolling, and single arm rows to improve bed mobility and start building strength for sitting at the edge of bed. And some patient education and a home exercise program for the care home staff to implement into their everyday routine that wasn't super cumbersome by adding more reps of rolling after they changed the patient from her adult briefs. So from this, we've definitely noticed an improvement in her ability to roll with now it's just min to mod assist. And I'd say now we're at a solid min to mod assist. And for sitting at the edge of bed, that is still very challenging, still max assist, but I think we're starting to build some muscle so that she can progress towards that much better. So if you want more info on scaling options for all sorts of patients, from acute care to home health to outpatient to the fitness space, please check out Older Adult Live, also Older Adult Level 1 and Level 2 online. The last 2 courses we have of Older Adult Live this year before the new year, we have Kingston, Ontario. So Christina will be at home for this course, December 6th to 7th. We also have Miami, Florida, December 20th, 21st. And the first course of the new year for Older Adult Live will be January 10th to 11th in Greenville, South Carolina. All right, everyone. I hope you all had an amazing Thanksgiving weekend. Lots of family, friend time, lots of rest, recovery, hopefully some workouts in there as well. And I will see you for the next podcast. Have a good one. Bye.